And increasingly, there is a challenge how we integrate diagnostic into therapeutic. That means put into the patient perspective. And it is still challenging, not only in Bangladesh, but many of the developing countries. And increasingly, we're facing difficulties even in the West. So I think this is an open discussion forum in the roundtable. And there is a presentation from Dr. Shahidul Islam Sikdar Rumi from BIHS, which will probably flag some of the problem we've been facing on the ground in Bangladesh. We have 25 experts joining us from all the leading institutes in Bangladesh and also from the United Kingdom, USA. We are expecting to have Dr. Tasbirul Islam, the chair of the PHA, and I don't know whether Tasbirul Islam is connected or not. Also, the trustee of the PHA, Mr. Shakil Farid from Papworth Hospital, as a cardiac consultant, as you know. And we also expecting to have BM Atiquzzaman from Florida Diabetes Center. And we have here Professor Fazlur Rahman sir, who is leading in Bangladesh. And also we have Salma Afrouz, madam, Professor Haq Mahfouz. We also have Professor Brigadier General AKM Mustafa Abedin, Society of Hematology President. We're expecting to have Professor Dr. Muhammad Salahuddin Shah, who is the chairman of the Bangabandhu Sheikh Mujib Medical University, Professor Ali Amin Lutful Kabir, and all the others. So I'm not naming as one by one. I think we will engage in the discussion. But first of all, I will invite Dr. Shahidul Islam Sikdar to present his case very shortly, within 2 to 3 minutes.
Thank you, sir. Thank you all. Special thanks to the Planetary Health Academia, as well as Hematology Society of Bangladesh and our BIHS General Hospital Authority for giving me opportunity to present in today's seminar, actually. I am also giving thanks to Texfinco Pharmaceuticals for coordinating today's program. So without further delay, I am just sharing our experience for a case, a patient with cancer, oblique blood cancer, overview of his real life picture. Before going in details, just a little bit introduction. Global scenario, cancer is the second leading cause of death and global annual economic impact around 1.16 trillion USD. And hematological malignancy comprises approximately 6.5% of all cancer incidents. So this figure, try to remember, only 6.5% hematological malignancy among the whole malignancy. And Bangladesh scenario, these statistics collected from the Globocon 2020, around 1.5 lakh people are attacked by the cancer every year and around 1 lakh die each year. So this is important figure for our country, which give more, creating more attention that how many people are affected and dying each year. So this is the real case. We face 65 years old male, middle class. He is known diabetic mellitus, hypertension, and had a history of gout. This patient at first referred to hematology from endocrinology department of BIHS General Hospital, especially for anemia evaluation. First evaluation revealed this is a case of iron deficiency anemia and beta thalassemia trait. After then treated with IV iron supplement, oral iron supplement, and along with other supportives. After then, you know, male iron deficiency has another clinical significance. So we referred this case to gastroenterologist or colorectal surgery of this hospital. This information is important, but this patient received consultation from other hospital gastroenterologist and underwent endoscopy, full-length colonoscopy as well. There is a cecal growth and suggestive of carcinoma of cecum, but no communication between the gastroenterologist primary consultant of BIHS General Hospital, and after the sample sent for histopathology to a lab having no facility of immunohistochemistry. An evaluation revealed it's a case of adenocarcinoma, no interaction between the histopathologist and physician. That means histopathologist producing report according to his own rules. And patient again came back to primary physician of BIHS General Hospital. After then, we referred this case to oncologist, then surgeon. After then, he underwent laparotomy, open biopsy as well. Open biopsy reveals suspicion of lymphoma by surgeon. After then, this surgeon from our hospital, integrated teamwork at BIHS General Hospital started, proper communication with primary physician, and now sample we sent for histopathological evaluation, having facility of immunohistochemistry. After then, this evaluation revealed this is a case of diffuse large B-cell lymphoma, stage 4, bone marrow was uninvolved, and planned for R-CHOP. But at that time, I had to go actually UK for my training purpose, and I discussed everything, treatment option, facilities, and referred this case to the actually other hospital having support for treating this case. But patient went to abroad due to family and social pressure. After then, he received first 2 cycles R-CHOP from India hematology department, spent 4.5 lakh taka for first cycle. But the second message is very much astonishing. Surprisingly, next 4 cycle R-CHOP received from oncologist of Bangladesh. Now again, patient came to our OPD, hematology OPD, for evaluation of anemia. This is in short actually case scenario. We omitted the clinical sequences, just the real picture we presented. Now we are focusing the observation from this case: lack of trust and belief between patient and healthcare provider, lack of interactive approach and teamwork. Many times biopsy taken only for histopathology, but we should consider other issue as well. Lack of one-stop center facility, lack of proper outsourcing facility. We know one hospital may not have all the facilities, but should develop proper outsourcing facility. And propaganda about health services, and for this area, a role for media and other sectors also important. And service area clarity for hematologist and oncologist actually not clear in practical life. Even adult and pediatric patient not clear in practical life. Sometimes patient give more pressure that we are interested to receive under adult hematologist, but patient is pediatric like this. And inadequate institutional practice due to insufficient remuneration in relation to need for healthcare providers. So this is our observation. We shared this case and observation in front of you because you know we just started our journey, hematology journey, 1st January 2022, and we are trying to develop a good cancer care center in this hospital, and our authority highly trying to develop this. So we are beginner and we are facing this kind of issue. If you incorporate this observation along with other interactive issue, we'll be grateful to you. Thank you all.
Yeah. Thank you, Dr. Rumi. This is a case which is a typical example of how integration between diagnostic and therapeutic can create the distrust among the patients. And I have a case from Nigeria last week, a young man, 24 years old. He had a neck lump, and biopsies been seen by the histopathologist on the eyes on microscope, and they say metastatic adenocarcinoma, and the clinician basically wrote him off. He's one of the family member knew that it could be lymphoma, so they sent the sample to some neighboring countries, outsourcing, and it was diffuse large B-cell lymphoma. So it's very common not only in our country. So integration between, you see, diagnosticians and the clinicians is so important, and your case is a typical example. Would get some more, I think, experience from the ground. Probably Professor Afiqul Islam, who was the head of the pediatric hemato-oncology in Bangabandhu Sheikh Mujib Medical University. Professor Afiqul Islam, sir, if you are connected and you can share the difficulties you face or you've been facing on the ground. I don't think we have Professor Afiqul Islam. Professor Mamtaz Begum, immediate past. Head of the Department of Pediatric Hemato-Oncology, National Institute of Cancer Research. I think on behalf of Professor Mamtaz, Sabina Karim, I think you can share your experience. You've been involved, I know, with lots of cases trying to integrate and outsource tested from across the world. Sabina Karim.
Please unmute your microphone. Please unmute your microphone, please.
You might share the experience you've been having with the retinoblastoma case recently. You've been involved and you found it very challenging. And I heard this child eventually went to Boston.
Yes, Sabina, we can hear. Please tell.
Assalamu alaikum.
Yes, Sabina, you can share your case, the difficulties you face with retinoblastoma case, for example, or any other cases. Very short, please. You have only 1 minute.
Hello?
Yes, we can hear. Please share. Probably technically.
Assalamu alaikum, dear learned audience. Do you hear me?
Yes, we can hear you.
বলতে পারছেন না, আপনি একটু mail দেবেন, তাড়াতাড়ি। আরে, এত ঝামেলা হলো কেমন করে হবে?
Yeah.
কই?
That's okay. We can move. I think we will hear you afterwards. Professor Salma Afroz, with the decades of experience in Dhaka Medical College Hospital and other institute. Professor Salma, madam, do you want to share your experience?
Unmute. Madam, please unmute yourself. Please unmute yourself.
কি করব? আমি আমাকে বলতেছ, আমি তো
Salma Afroz, madam, please unmute yourself. Unmute. You are muted.
Yeah. Probably should go to Bangabandhu Sheikh Mujib Medical University, Professor Salahuddin Shah, if Professor Salahuddin Shah is connected. Otherwise, Dr. Amin Lutful Kabir, please.
Amin.
Yes.
Sir, assalamu alaikum. Assalamu alaikum, sir.
Can you hear me?
Oh, we can see you and we
with something, that's why I put the video and the sound off. But I'm all right now.
thank you, sir. Thank you, sir. Welcome on board. We can see you and we can hear you as well. Thank you for joining. Dr. Amin Lutful Kabir.
Yes.
Can I suggest something?
Yes,
Can
sir.
I suggest something, Amin?
Yes,
I
sir.
will be, I shall be, inshallah, hopefully in London on 6th.
Experience, how you finding it's difficult to integrate between diagnostic and therapeutic to treat your patients in BSMMU? Thank you.
Yes, thank you, Professor Dr. Amin Islam and organizer of Planetary Health,
Sabina, you can mute yourself, please. Yeah.
Planetary Health Academy and the Association of BISS and Hospital, and for organizing this nice and integrated and difficulties in aspect of diagnosis and therapeutic in blood cancer in hematological malignancy. So we face some many cases to when diagnosis is very difficult, because sometimes we are very reluctant in cases to do the trephine biopsy. In trephine biopsy, it's very important to rule out some basic diagnosis of some leukemia and some other myeloproliferative neoplasm. Sometimes the diagnosis is very late. Recently, I have diagnosed a case is after 6 months, they're doing the bone marrow several times, but we don't, nobody does the trephine biopsy. And this later diagnosis is the myelofibrosis, the reticular stain, and others molecular studies. And eventually, this sometimes patient present with the pancytopenia, and there's no blood in the peripheral blood. Sometimes we do the bone marrow, and sometimes there's a dry trap or blood trap. There's no blood. So trephine is very, very important in respect of diagnosis in hematologic malignancy. This is my message to everybody who do the bone marrow. Please do the trephine biopsy, at least for cellularity to confirm diagnosis, other immunohistochemistry, and future research purposes. Trephine is very important. This is I face difficulties in diagnosis and others is of course there's some biopsy immunohistochemistry sometimes it reveals the non-Hodgkin, sometimes in a specific diagnosis. So immunohistochemistry reveals there is actually no malignancy, sometimes the non-specific findings, and some times we do different diagnosis. So comprehensive immunohistochemistry and integrated with the histopathology, which is very important to definite the diagnosis of the patients. Thank you.
Thank you, Dr. Amin Lutful Kobir. It is very important to talk to our colleagues who is involved with the care, especially the radiologist, histopathologist, because we have few histopathologists on the ground. We have to understand, and they are inundated with thousands of cases every week and every month. So when we do not talk to each other, do not get enough information, I'll tell you, it is so important that you can make diagnosis of anaplastic large anaplastic lymphoma to classical Hodgkin's lymphoma. But if you talk to the physician as a histopathologist and the radiologist, you will be able to make the diagnosis. Otherwise, you will just make a diagnostic error and patient will be harmed. So talking to each other, getting clinical information to diagnostician is so important to provide the safe service of a patient, and we know it every day. Sometimes we as a physician, we just send a block to histopathologist and we don't say anything. And the histopathologist is very scared to make the comment because sometimes it's not that easy to make the comment. So when you have a clinical information or speak to the histopathologist to say, this is what I'm thinking. For example, if you have an EBV, viral infection in a young girl, and if you don't say enough to histopathologists, they will confidently make a diagnosis of Hodgkin's lymphoma or BLPD, and that happens every day. But if you say, I have done the EBV, the clinical features is of EBV, and the EBV copies is millions, they will interpret accordingly, because we know that immunohistochemistry sometimes is not that difficult or available in our country. So talking to each other is very important, and radiology is also so important, as well as the histopathology, the microbiology. Professor Haq Mahfouz from Combined Military Hospital might share his experience because he has set up a hemato-oncology and transplant unit, which is very effective and working very well on the ground for Bangladeshi people. Professor Haq Mahfouz from...
Thank you very much, Dr. Amin. And I also give thanks to the Planetary Arcadia to arranging such a time-demanding topic for discussions and roundtable talk. So my experience, what I should say that in our country, am I clear?
Yes, sir.
In our country, so I'll tell the total perspective in our country. So in our country, modality of test is very limited. Quality of test is also not good enough, and cost of test is also very, very high. And many of the hospitals and institutes, they don't have the diagnostic facilities properly. So either they can treat or they can diagnose this. So in my country, in our country, so cytogenetic test is limited. We can't do HLA typing properly. We have got no properly MRD test facilities. We can't, drug monitoring is also sometimes very difficult. We also can't detect virals and fungals in many of the cases. PET-CT is not available many of the setups in my country. So for what we need to treat a case, we need to pinpoint diagnosis. So pinpoint diagnosis is very much important to give the proper treatment of the patient. So pinpoint diagnosis is very important for the treating the malignant cases. We can't say that is AML. We need to say what type of cytokine abnormality this patient have, what is this, so what is the genetic abnormality, and then we can do the proper treatment of the patient. And the success comes out with this. So this is the one of the great problem we are facing in our country. And in my experience, some of the cases like multiple myeloma, the patient might have the pain, this patient might have renal impairment. So this patient, when they pain, they go to report to orthopedic surgeon. And orthopedic surgeon, they don't bother for they can't diagnose the multiple myeloma, and they're treating the pain. And when this patient landed to hematologist, already major damage occurs. And this type of patient also sometimes report to nephrologist with renal impairment or creatinine level high. And this patient is treated by the nephrologist with creatinine level. So when they landed to hematology, already the patient problem is danger already happened. So this referral habit is also less in our country. What I tell, the referral habit is also less in our country. So this should be also take into cognizance that we should refer the case. When it is not our case, we should refer the proper place so that the patient can get better treatment and the cost is reduced and the successful outcome comes. So these are the problems we are facing. So if we integrate the diagnostic facility in one center, that will be better for the patient. Like if we can set a nice or beautiful hospital with all the facilities of investigations, then in one roof we can give the patient with treatment and the diagnostic service. And the patient is cost will be less for this kind of cases. In my hospital, we address some of the cases that was with hospital. So our success rate is comparatively better than the other institutions, and we have got a less drop of patients. Since it is an army hospital, so these patients get one chemotherapy, then he can again admitted for the second chemotherapy, then again for the third chemotherapy. So ultimately, these patients doesn't drop out. But in other hospitals, I believe these patients admitted once, then second time it is very difficult for him to admit in the government hospital, because rush of the patients and the load of the patients doesn't permit this patient to admit again. So this is one of the cause that these patients can't get better treatment. But in army hospital, this doesn't happen. So we are a bit in a better position in that cases for the treatment of the cases. So I think if we can consider all these things, then we can make our treatment facilities better and better for the patient. Thank you very much.
Thank you very much. This is a beautiful example.
Assalamu alaikum.
I think Professor Salahuddin Shah will come to you in a minute.
And good afternoon.
Thank you. Good afternoon. Thank you. I'll come to you shortly. We'll just make a little comment on the case we just discussed in the center from the CMH Dhaka. The only thing is here we have kind of Professor Haq Mahfouz, we kind of created a pathways so important to avoid the referral delay. If a patient comes in with back pain, not traumatic, non-traumatic, and has a fracture, for example, or problem with the spine, they always get evaluated for cancer, including serum free light chain and serum protein electrophoresis, and thereby we get these patients earlier than later. So it's all about, you see, the creation of the pathway which avoids the delay and subsequently treatment. Professor Salahuddin Shah, we were missing you, and Professor Dr. Amin Lutful Kobir has highlighted some issues. Do you have anything to add in terms of integration, diagnostic dilemma? You are muted, Professor Salahuddin Shah. You are muted. Unmute yourself. Yes.
Oh, thank you so much. Thank you, Dr. Amin Islam. Really, he's doing very well in the field of hematology. He's working in UK, but actually, I may think, or we may think that he's always working with us. The initiation which have been taken by him really historical, and it is our failure to take some initiation beforehand. But finally, as he's taken this initiation, I would like to give him big claps and congratulations and thanks. And really, this platform will help us to think what we need in our country to provide integrated one-stop services for the hematological disorder. All of you know, I'm working at Bangabandhu Sheikh Mujib Medical University, and our hematology department is the father of hematology in Bangladesh. And most of the hematologists, they have received their post-graduation degree and training at Bangabandhu Sheikh Mujib Medical University. And yet now, though we have many other medical universities, but still now, Bangabandhu Sheikh Mujib Medical University is the only one university who is working with his full strength. So, many of the speakers, or I have heard the speech of Haq Mahfouz for the referral center. I think Bangabandhu Sheikh Mujib Medical University can be one of the referral center, as because all the postgraduate teaching initiated and it maintained, and all the degrees of postgraduate degrees are given from our department, especially MD, MS, and others, and FCPS from the BCPS. So we need two platforms. One platform, National Institute of Hematology, and another platform could be option, that is Bangabandhu Sheikh Mujib Medical University, where from the hematologist will be trained to provide services later. So giving this two impression, I would like to conclude my comment on today's roundtable discussion. And this is one of the time-demanded roundtable discussion. And really, I am grateful and thankful to Dr. Amin Islam, as he's arranged this nice roundtable discussion. So my proposal is to set up in our country a National Institute of Hematology, which will deal all the hematological disorders, keeping all the laboratory and other facilities under one umbrella. Another one, that is university, and university can take initiation, and I myself and my department, my university will take the initiation. We'll try to set up all the investing other facilities, as because postgraduate students are coming here for the training, even then from the FIP and from other medical colleges and from other institutes. They are placed, and all the exams are taken from here. Thank you very much. With these two remarks in the management of hematological disorders, I'd like to conclude my comment on today's roundtable discussion. Thank you. Assalamu alaikum.
Thank you. Assalamu alaikum, Professor Salahuddin Shah, for your beautiful comment and direction as well. And as you know, you can take an example of the National Health Service. It's in the UK. It's a small country, big country compared to Bangladesh, but obviously a small system, but it's so robust. And you can take an example. If you take all the patient to the Bangabandhu, I think you will be inundated. You can't provide the service. So there has to be a referral pathway. For example, if I have a difficult TTP patients, it gets to UCL. But if it is like a HAS or DIC, we don't need to discuss. So creating a good pathway and which patient to refer to which hospital, that's important. And obviously, BSMMU as the main teaching hub should be the tertiary referral center for our patient, where we can also learn lots as a team and with our student and the trainees and lots of other specialists as well. So thank you very much. With all this, I think we have a case in the BIHS General Hospital in Dhaka. Dr. Sadek, who is the chief consultant surgeon in BIHS, you have a case, I think that's very interesting. And that case we can quickly discuss, and it's very common actually in hemato-oncology with a patient who has intestinal obstruction or retroperitoneal mass causing ureteric obstruction or other obstruction, and you operate and you think it's lymphoma, and how to evaluate, how long you wait before you start treatment, for example. because some of this lymphoma, as we know, is rapidly growing, and you will not have much time to wait for the histopathology report, for example. And as you know, sometimes you don't need to operation. You just give steroid and patient gets better. So do you want to share your case who is an inpatient, I think, in BIHS General Hospital? Dr. Sadek?
Yes, connected. Most probably now this.
Okay. Yeah, you can briefly mention this. I think that should be highlighted because every time, even in the UK, that the patient is harmed as a result of diagnostic delay and dilemma and the delayed initiation of the very vital life-saving drugs, for example, methylprednisolone or steroid. Do you want to share this case quickly, because you have lots of expert
Few months ago, we faced a case actually, chronic mass diagnosed as a case of lymphoma later on. But after the surgery, we plan to give steroid actually, and we gave dexamethasone, but day 3 patient developed inflammatory condition after then use abscess in the whole abdomen. Later on, actually, we cannot continue the steroid, but we had a plan to start rituximab as well. But after then 1 month later, we can start total treatment for that patient actually.
Yeah, so this is so important. For example, Burkitt's lymphoma and high-grade lymphoma, if you wait 1 month, definitely your patient will be dead. So you can't wait, you see, it's just time is of essence. So treating the infection, removing the abscess, and giving steroid and rituximab, which is very good. You go to the reverse order. And we have a patient, LH, 51 years old lady, opened the abdomen for suspected ovarian mass, but actually when they opened it, it was a massive lymphomatous mass. They took the biopsy, closed it, sent her home a few days after. Obviously, guess what? When they're waiting for the biopsy result, she was readmitted again under who? Under the surgeon. So surgeon counseled the family to say, look, you had a big open wound. We can't do anything about it. We're going to give you steroid. And 4 weeks time, you will probably have the result of the histopathology back and we'll start treatment. She rapidly deteriorated with a massive pleural effusion, hydronephrosis, nephrostomy done. We started methylprednisolone, tazocine, and you name it. And this lady in day 20 at the moment, she received full polar chip chemotherapy and she's walking in the ward. Hopefully tomorrow we will be able to discharge her. But she was a definitely dead case. So you cannot wait. And for a patient post-operative 3 day to have abscess is very uncommon. So probably there's something else in it. And waiting is dangerous for this patient. And obviously you need to counsel the patient, the risk of death and risk of infection, deterioration, etc. So again, I think this is an integration is so important. And we didn't wait for this lady 3 weeks to get the immunohistochemistry. We phoned the histopathology consultant, gave him the scenario, and he did a rapid CD20 within a couple of hours, and he said it's high-grade lymphomas. So you see that rather than waiting, emailing, writing referral, if you speak to people and explain the diagnostic dilemma and the delay causing the harm, they will expedite for you and they will help you as well. And your gastric outlet obstruction patient, you have given the suspected lymphoma gastric outlet obstruction. She's emaciating. The patient cannot have TPN because they're poor. And you have given dexamethasone, which has not helped. And you're now giving methylprednisolone. People wanted to give R-CHOP, for example, but you don't have a CD20. So we should do a CD20 very quickly if possible as well, and talking to the histopathology, immunohistochemistry, and get the R-CHOP or CHOP, that's important. So this is very common, not only in our country, in Bangladesh, it's everywhere. And this is again.
Last case, I want to mention one thing, that this case that you mentioned lastly, gastric outlet obstruction, the major important thing is we can make interactions with the histopathologist, surgeon, as well as hematologist to take a proper decision. So after all, we gave 4 days dexamethasone, then 2 days methylprednisolone, no improvement. Later on decided no CD20 positivity. Mostly this is a non-hematological malignancy. But
Absolutely.
this is not the real thing. Real thing, we can make an interaction with the other discipline, working as a teamwork actually.
No, absolutely. You see, because a surgeon opened the tummy and he thinks the way he looked at it, it's lymphoma. But the lymphoma are usually high grade, or if it is a marginal lymphoma, it might not work with the steroid. But if it was high grade lymphoma, you see improvement, dramatic. And again, as we say, that you think about something else, nowadays we do see miracles all the time. We're seeing one thing from our experience, it looked like this, but actually it's not this. And your patient is probably not lymphoma at all, it's probably something different. So early talking to not only hematologist, in any specialty, you go respiratory, you go neurosurgeon, and you name it, spinal surgeon, if there is a metastatic cord compression and you are waiting for the surgery, your patient is paralyzed rest of their lives. But if you are proactive, do the blood test, speak to people relevant, AOS, acute oncology service, for example, it could be metastatic any cancer, prostate cancer, lung cancer, and so on. And if you give a bit of steroid, take the biopsy, give the radiation, there is about 80% chance this patient will be mobile and active and walking. But if you just go home, leaving this patient, an interventionist will come and do the biopsy tomorrow or next week, definitely that's cause harm. But it's talking to each other. But you are facing a huge volume of patients on the ground. We need to increase the capacity as well at the same time. Do we have Professor Akhil Ranjan Bishar? Professor Akhil, I think he's in Colorado, I think United States. Akhil from Dhaka Medical College Hospital, head of the BMT and Hemato-Oncology, Dhaka Medical College, he said he will be able to join. Professor Akhil. Anybody else from Dhaka Medical? Anybody from BARDEM apart from BIHS? I think Rumi is representing both institutes, I think.
Azad Khan sir from Bardem, currently connected.
Yes, he came in and he talked and he had to leave. So he was there as well. From the head of the medicine, I think we have Professor Dr. Muhammad Nazmul Haq, gastroenterology. He might. Yes,
Yeah.
sir.
Yes,
Do you have
sir.
any comments, sir, about this case?
I'm
Or any
here.
cases? Yeah. Because
Actually,
you might be seeing lots of T-cell lymphoma, anaplastic lymphoma, high-grade lymphoma in the when you do the endoscopy or colonoscopy. Please, yeah.
yes, sir. Actually, this topics is diagnostic and therapeutic combination. This is really very challenge for us. Actually, we diagnose on endoscopic or colonoscopic basis along with the clinical parameters, and sometimes we send the sample and getting the report. But nowadays, the concept of cancer treatment has been totally changed, and it is saying that it is targeted therapy for establishing the targeted. We need so many immunohistochemistry. And ultimately, we send the patient for the oncologist, and they do everything. And there is actually no integration between the oncologist and among with us. We usually got the patient return after 6 months or 1 year later. The oncologist send us to do an endoscopy or colonoscopy to see any recurrence of the disease. But actually, we totally miss what happened in between. So the thing is, totally, there is no integration between us, between the primary physician along with the oncologist. This is really very problem for us. And another thing is for during the immunohistochemistry, as we all know, the facilities is still limited. And actually, today's discussion, actually, I think we may improve our collaboration. And it really very helpful if we can establish a single one-stop center. Then in this way, we can learn so many things and we can share our knowledge as well. Thank you, sir.
Thank you. Thank you very much for your insight into the complexity we are facing. And it is not easy. It's a big service and a national drive, because those country who has got national strategy and has money and invested into manpower and infrastructure is slightly easier. But for a country, we have lots of other problem, huge population as well. And also one thing Professor Salahuddin Shah and Haq Mahfuz and all the others here, we need to train our doctors better. Obviously, to retain a doctor in a city hospital, obviously, if we want to attract them to spend more time in the hospital than running for some money outside, which are they bound to. If I give only 40,000 taka to a trainee in Bangabandhu or some others, I will have to definitely go, compromising my training. So I think we as a nation and the Department of Health and others need to come together to work together for the better of our patients and the trainees and the doctors as well. And this is very much challenging, and hopefully things will be improved day by day. Professor Rafiqul Islam, I think pediatric, we didn't get much. But Sabina Karim, are you able to talk? National Institute of Cancer Research, or probably we can have Mohammed Ali, who is the Society Secretary, Hematology Society Secretary, and the head of the Department of
Unmute yourself. Sabina, unmute yourself.
Dr. Sabina Karim, or Mohammed Ali, who is the head of the BMT and Hemato-Oncology unit in Cancer Hospital in Dhaka. Either of you, if you are connected.
Sabina, please unmute yourself. Unmute. You are muted now. Unmute, please. Sabina, you are muted.
Yeah. I think we have the histopathologist.
Assalamualaikum.
Yes.
Yes.
Yeah.
Amin, do you hear me?
Yeah, we can hear you pretty quickly. You can share your experience, yes, from NICHR perspective.
Assalamualaikum and good morning to all. I am Dr. Sabina Karim, working as Assistant Professor, Pediatric Hematology and Oncology Department, National Institute of Cancer Research and Hospital. And I am working there from 2009. So I have huge practical experience actually in treating pediatric oncology cases in government sector. So our department is very enriched with 8 qualified pediatric hematologists and oncologists. In the government sector, main problem is actually financial. If we support the patient phase by phase, leukemia and lymphoma is in pediatric oncology, is highly curable. So patient needs only support in case of counseling. When a patient with Burkitt lymphoma came to us, though very advanced stage, but we can still cure. But patient needs support in the form of to control infection, and during high dose methotrexate, patient needs tremendous support. And we are lacking in case of lymphoma only in case of immunohistochemistry, which takes a lot of time, sometimes more than 3 weeks. So we have to decide from clinical presentation or histopathology. We know that it is Burkitt lymphoma or T lymphoblastic lymphoma. Treatment approach is different. Both are curable, highly curable in our hand. And National Institute of Cancer Research and Hospital has chemotherapy medication supplied from the hospital. Despite that, patient needs support and proper counseling and timely financial support, phase by phase, not all. Hospital can support 50 to 70%. If we come forward and support our patient, only 30 to 40%, they can survive. And I want to give some example. One of our patients came from Lalmonirhat a 6 months back with 2 lakh discount, ALL patient, and nobody with him to support him for few days. He is in respiratory distress. When we go for round, he tells what medication he is taking, what is going on. Nobody with him, no accommodation, no near and dear one, and he's an orphan. His uncle and grandmother come with him. I requested grandmother to stay with him because he will be cured. Grandmother denied that he need some Boysko Bhata, you know, otherwise she cannot survive. So afterwards, there was a shelter home called Alok Nibash. We talked with them and they supported the children, and financial support regarding medication and all other things are given by us from our poor fund and from our hospital. And the child is so smart and sweet. Now he comes alone and he never wants us to that we can support him all the time. He manages his everything from Alok Nibash and his uncle and other people, and never demand that give me this thing or that thing. He is very happy, and we cannot do the bone marrow because child has respiratory distress. We have to start treatment without immunophenotyping as high risk ALL, but he is doing well. This is the actual scenario. And in case of lymphoma, Burkitt lymphoma, patients are highly curable. We try to support our patient, but our main difficulty is immunohistochemistry report. We cannot divide Burkitt lymphoma and lymphoblastic lymphoma from the very beginning. And
Sabina, I
another
have to stop.
problem.
Sabina, I have to stop you here because we're running out of time. We heard you're doing a fantastic job. A little bit of more integration, it would be much appreciated. We have heard all these difficulties on the ground. We have Ubaid Tanzim from Imperial College. He is doing an artificial and machine learning. You hear about artificial intelligence in medicine and cancer medicine and so on. Ubaid would say two minutes about what is the brightest future in cancer medicine coming to the world. We already started in some aspects here in reducing imaging and others and data analysis. Ubaid Tanzim, do you want to say 1 minute before you go?
Assalamu alaikum, everybody. Thank you for inviting me on this esteemed platform. It's lovely to share a stage with some of our professors and clinicians. So thank you to the PHA and the BHIS for inviting me. So we're discussing today the integration between diagnostic and therapeutic. And at the moment, artificial intelligence and machine learning is, in the front line of the news. We are on a cusp of a data revolution. And I feel like artificial intelligence can be the bridge, especially in developing countries, to help, bridge the integration to diagnostic and therapeutic. So a few of the common themes we mentioned today were, especially related to cancer, early detection and diagnosis. So as clinicians, our sort of general practice is all algorithmic. We are experts at pattern recognition, and this is exactly what machine learning does. So with specific regard with cancer and blood cancer, IBM's Watson. So IBM is one of the biggest, computer industries in the world. Some of you may have had an IBM computer in the past. So IBM Watson is an institute which has analyzed oncology medical records, research papers, and patient data to assist doctors in diagnosing and creating personalized treatment plans for cancer patients. So this is where this artificial intelligence and machine learning algorithms are taking place. Another thing we mentioned was with regards to communication between specialties. So, the discussion today, we mentioned that sometimes the histopathologist may not speak to the surgeons may not speak to the cancer, our cancer colleagues. And this is where a AI or a machine learning algorithm can help. It can help bridge that gap. It can help aid with clinical decision support by being able.
Please unmute yourself. Why? Please unmute. Yes.
Sorry about that. By being able to triage these patients, and it can expedite clinical decision support by making the appropriate referral and making sure that these referrals are streamlined. So, like I mentioned, we are at the cusp of a data revolution, and artificial intelligence is at the heart of furthering our potential as clinicians and our potential in cancer medicine. So that's just a very quick run through of what's in store in the next couple of years with AI and machine learning. I hope that was useful.
Thank you, Ved. Thank you very much for shedding the lights on the artificial intelligence and machine learning, which you are doing in one of the fascinating institute in the United Kingdom, Imperial College. And hopefully you can help the nation as well in future and days and years to come. Thank you, Ved, for connecting. We have oncologist Professor Dr. Happy Hawk from the Bangladesh Institute of Health Science. Happy Hawk, you might share your experience, what difficulties you've been facing. Professor Happy Hawk.
Madam, please unmute yourself. You are now muted. Please unmute yourself. Dr. Happy Hawk, you are now muted. We can switch over to our next. We can switch to next, most probably.
In that case, I think we heard the problem we've been facing on the ground. And it's not only, believe you me, it's not only in Bangladesh, it's most of the developing country and even developed countries with the increasing number of the patients, also diagnostic complexity and availability of the testing, you name it. All the patients get PET CT and whole body MRI scan as and when necessary, increasingly, and that creates lots of patient pool, obviously, most referral, and we detecting more and more cases, and obviously patients are living longer and longer, which is what we hear and we care for. I think in that case, we probably see whether Tasbirul Islam is connected, the chair of the PHA from Chicago. Tasbirul Islam. B.M. Atikujaman, trustee, the professor gastroenterologist from Florida. Mr. Shakil Farid from Cardiovascular Hospital, cardiothoracic consultant from Papworth, Cambridge. I think they left that busy schedule. Rumana Rashid. Rumana Rashid's father was the founding hematologist in our country and the founding chairman of the hematology in Bangabandhu Sheikh Mujib Medical University and Society president as well. She, I think, a bit busy, not connected. Dr. Mahdi Hassan, who has lots of experience treating patients as an assistant professor in Dhaka Medical College and currently a consultant hematologist in Leicester Hospital, United Kingdom. Dr. Mahdi Hassan.
Amin. Yeah,
Yes.
I'm here. Can you all
Just share your thoughts on how we can help our beloved country integrating together?
It's a big statement, helping. I got to be very polite. I'm just here to listen, actually. I didn't expect that I have to speak on this platform, but thank you very much for inviting me. I gather most of us here in this meeting all speak Bengali, so am I allowed to speak
Please, yeah.
in Bengali? Unless there is any foreign listener, or I'm more than happy to speak in.
No, that's okay. It's a global meeting. You can see from the full continent, from Australia to United States, lots of people connected here. But most of them, as you say, is Bengali, so you can share your image and also in Bengali.
Thank you very much. That's great. And may I ask, how much time I have got before I start?
You have probably 2-3 minutes, yeah.
Okay, I'm just listening to this, to all the conversations, and আমার যেটা মনে হয় আর কি বাংলাদেশে কিছুদিন কাজ করার অভিজ্ঞতা সরকারি চাকরি সুবাদে ঢাকা মেডিকেল দেন জিএমআর না এখন বিএসএনএমইউ এবং কিছু প্রাইভেট সেক্টরে কাজ করার সৌভাগ্য হয়েছিল, তাও সেটা অনেকদিন। সুতরাং আমার অভিজ্ঞতা মে নট বি আপ টু ডেট, বাট আমি যেটা বুঝি আর কি যতটুকু, সেটা হচ্ছে যে আপনার যে কোনো এটাকে যদি সার্ভিস বলেন, আপনার গভর্নমেন্ট সার্ভিস অথবা প্রাইভেট সার্ভিস, স্ট্রাকচার ইজ অলমোস্ট দ্য সেম। আপনার এক সাইড হচ্ছে ডায়াগনস্টিক, তারপরে হচ্ছে আপনার ট্রিটমেন্ট, আর তারপরে হচ্ছে আফটার ট্রিটমেন্ট কেয়ার। সো আপনার যেটা আমাদের করা দরকার সবার, সেটা হচ্ছে যে স্ট্রাকচার, the networking and the and the frameworking. So এখন আমি সাবিনার কথা শুনছিলাম যে রিসোর্স ইজ এ প্রবলেম। রিসোর্স ইজ অলওয়েজ এ প্রবলেম। ইটস নট জাস্ট বাংলাদেশের জন্য, যে কোনো ফরেন কান্ট্রি আপনি বলেন, বাংলাদেশ ডেভেলপিং কান্ট্রি বা ডেভেলপ কান্ট্রি, ইভেন ইন NHS, even in the big centers, resource is always a problem. Money will always be short, never enough. So প্রথম কথা হচ্ছে যে যদি আমি আজকে হঠাৎ করে রিসোর্স পেয়ে যাই বাংলাদেশে, প্রাইভেট অথবা গভর্নমেন্ট সেক্টরে, আমার কি সেই স্ট্রাকচার আছে? ইজ ইট রেডি টু রোল অন? সেটা হচ্ছে আসলে আসল প্রশ্ন। তো আমি যেটা বুঝি এখানে, আমি মাঝে মধ্যে যে সমস্ত রিপোর্ট আসে, সেখানে আমি দেখি বাংলাদেশে ইটস এ ভেরি এক্সাইটিং টাইম। আমি 30-35 বছর আগে কাজ শুরু করেছি বাংলাদেশে, তখনও আমার আমি প্রফেসর রশিদের সঙ্গে কাজ করতাম। উনি বলতেন যে ইট ইজ ভেরি এক্সাইটিং ইন হেমাটোলজি। 30-35 বছর আগে ছিল, এখনো আছে। উবায়দের কথা শুনলাম, ইটস ভেরি এক্সাইটিং টাইম কামিং আপ। কিন্তু আমার যেটা মনে হয় সেটা হচ্ছে যে আপনার আমাদের সবার এই সার্ভিসকে যদি অফোর্ড করতে হয়, তাহলে একটা নেটওয়ার্কিং সিস্টেম করতে হবে বিটুইন ন্যাশনাল এন্ড ইন্টারন্যাশনাল, এবং you have to take everyone on the board. It's not just the doctors. They start diagnostics, people from the diagnostic, and people from the therapeutics, and also don't forget the people from the management administration. They will be an immense help to run the service. You will need professional doctors, technical hands, and also general people and the entrepreneur, who will be investing in this service in the future. So it's an integration of many people, taking everyone on the board and integrate with each other, talk to each other. The other thing is the human touch. আমি মাঝে মধ্যে দেখি যে যেখানে আপনার অনেক বড় হাসপাতালে, বাংলাদেশে অনেক নাম করা হাসপাতালে গেছে প্রাইভেট সেক্টরে, বাট কমিউনিকেশন ইজ নট দেয়ার। আপনার এখানেও কিন্তু আমাদের খানিকটা গ্যাপ আছে, এবং আমি কখনো বলবো না যে এটা শুধু বাংলাদেশে, এখানে ইংল্যান্ডেও বা আপনার যে কোনো জায়গায় কমিউনিকেশন ইজ এভরিথিং। সুতরাং পেশেন্টের সঙ্গে কথা বলা এবং অন্যান্য কলিগসদের সঙ্গে কথা বলা, আজকাল তো কোনো অসুবিধা নেই। জাস্ট পিক আপ দ্য ফোন এন্ড স্পিক টু এনিওয়ান, দেয়ার ইজ নো হেজিটেশন। উই আর অল কলিগ, উই আর হিয়ার টু হেল্প ইচ আদার। আমরা সবাই মনে রাখি যে আসলে এট দি এন্ড ইটস নট অ্যাবাউট আওয়ার পার্সোনালিটি, ইটস অ্যাবাউট the patient in the center, and that's the most vital thing. Think about the patient in the center and do whatever you needed to do with everyone on that board, doctor, nurses, colleagues, from all sectors. So etai amar kache mone hoy je this is what we should be start doing before money and everything starts to roll on. And I'm very hopeful বাংলাদেশে যেরকম ইকোনমি দাঁড়াচ্ছে, যেরকম ভাবে চলছে, in the near future, not far from now, we will be a prosperous nation, and to be honest, and at that time, আমাদের যাতে কখনো আফসোস না করতে হয় যে আরে আমাদের স্ট্রাকচারটা তো এখনো ডেভেলপ করিনি। সো এখন যেটা দরকার, let's start the structure first. Thank you very much for giving me the time and opportunity.
Thank you, Dr. Mahdi Hassan. Thank you. As you said, it's a very good statement that we're trying to integrate. It's already integrated the communication and ethics in our curriculum in Bangladesh, working very hard with the BCPS and the Department of Health and Ministry of Health and so on. And many of the litigation and the problem and the fighting in the hospital, big tertiary hospitals, people comes in, rush through and destroy the facilities, the harm doctors and the nurses. And it is mainly the communication. We're not communicating very well at all. We have to be a bit patient. When a patient or patient's relative in the hospital, we have to have empathy and give time to explain. And believe you me that if you explain to the patients and relative in a nicer way, you will definitely avoid the conflict and beating doctors in the hospital. It is very sad to see many of the even 5-star hospital having this ill-trained doctor, not only in Bangladesh, in many other countries. And it's also only not the knowledge, because you can speak to anyone to say, look, I am an ITU doctor, and this is the patient I am doing. I will speak to my professor and doctor and get back to you within 10 minutes or an hour. And you avoid the conflict. And this is what we are integrating gradually, and it is being done so nicely at the moment. So hopefully in generation to come, you will see more people with providing the better services. We heard all of our intellectual medical problem and dilemma. I see here we have just retired senior most justice of Bangladesh. You will know him. Justice Iman Ali is connected here. So from the non-medical perspective, Mr. Iman Ali, Justice Iman Ali, if you want to say something for us, Justice Iman Ali, senior most justice, retired in December from Bangladesh.
Thank you, Dr. Aminul Islam. Assalamu alaikum. I'm not, of course, a medical person. I have no ideas about medicine, and particularly no ideas about the topic that you're talking about, hemato-oncology. But I can tell you one example that came to my life about 2, maybe 3 years ago. When I took my mother, she was at that time 90 years old, to Sylhet. And then she was in the village and suddenly she caught a cold. She wouldn't tell me, but I've heard on the phone that her breathing was not normal. So I quickly went from Dhaka to Sylhet, took her to Usmani Medical College Hospital. Now there, the very day she was entered, she had a heart attack. So then she was diagnosed with pneumonia. She had a heart attack and she had also bad renal function. She had water in the lungs. So many different aspects of her body were suffering all at the same time. Now, luckily, I must say, I give all thanks to the professors in Usmani Medical College Hospital. What happened was that each of the heads of the departments joined together in one meeting, and they decided what medicines to prescribe, what actions to take, and of course, they were able to decide the effect of each of the medicine would have. So because of the renal function failure, some serious or severe medication could not be given. On the other hand, medication had to be given to reduce the water in the lungs. Medication had to be given to control her pressure. So all had to be balanced. And I must say, I'm so grateful to the professors because they were able to discuss between themselves in one meeting, and I was present in that meeting. They were able to discuss the negatives and positives. What would happen if so much medicine was given in this aspect? What would happen if no medicine was given for this purpose? And alhamdulillah, at the end of the day, they were able to control everything. And my mother was cured. She was put in a unit which was unfortunately very next to the COVID unit. And there she caught COVID as well. So on top of that, everything else, she had COVID. But luckily, she survived all of it. And as I say, it was a combined effort of all the professors that I think led to the positive result. And I think that is the important aspect that I would like to highlight. And I think some of you have already highlighted the correlation between the professors dealing with different aspects of the human body and then coming together and explaining the relative aspects of each part of the body that was being affected. Thank you for giving me the opportunity to say these few words. And I wish that so much more could be done in Bangladesh for our people. We are a very poor country, but I think with effort, we can do better than we are doing at the moment. Thank you very much. Assalamu alaikum.
Walaikum assalam. Thank you, Justice Iman Ali, for your insightful sharing of your mother case, and gladly she recovered and she's well. And this
Dr.
is
Amin,
an
can
example.
I get 1 minute time?
Yes, please, Professor Haq Mahfouz from Combined Military Hospital, Professor Brigadier General Haq Mahfouz from CMH Dhaka.
Thank you very much. I just want to talk in the light of the Justice Iman Ali, what we are doing in our hospital. You know, in our hospital, we have got very limited number of specialists, only 4 specialists and only 2 training. But we are keeping 50 inpatients all the time, and we are doing transplant as well, you know. We have already completed 73 transplant cases and almost with a very good result. So what we're doing, we have got very interpersonal relationship among us. We do all the combined effort and joint collaboration to treat all the cases, and we give the joint round and joint case discussion, and we do frequent medical board. So this brings very successful result in our cases, and nobody in our setup is enough to treat the cases. So we always do accumulative collaborative efforts to treat the patient. And we also train our nurse, our housekeeping. So nurse and housekeeping is also very important to treat and to give the better outcome for the patient. So since we have got limited resource in our country, so we need to do accumulated efforts so that it brings a better result. And we are doing this, and this gives a better result for us. I think if all the institutions in our country do like this, they can give better support to the patient. Thank you.
Thank you, Professor Brigadier Haq Mahfouz from Combined Military Hospital. I know the amazing pathway you have created, and he took me to the ward in a military hospital, and it's a massive ward, and his healthcare assistant was presenting a case so beautifully. Day 13 of acute myeloid leukemia, dark chemotherapy. This patient is on BTD, this patient is on CTD, etc. And they knew the observation, mu score, etc. so nicely. And we need to adopt, and we need to get this experience to the other hospital as well. What Justice Iman Ali's mother received in Sylhet MAG Usmani Medical College Hospital, we would like every patient to receive the same care and case. And to do that, we need capacity building. We need, obviously we have infrastructure. We need to just get a bit of bed management. I don't know the bed, I mean the patient's bed. Lots of patients sitting on the floor and on the bed, but actually there is no flow management to see why this patient is still there for 3 months, 2 months. So I think we need to restructure, and hopefully with our joint effort, we will be able to help and integrate better and better every day. So I hope these sessions were useful discussion. Obviously, now we need to take this on and get into our policymaker and the authorities in various hospitals. And the BARDAM and the BARDAS, I'm so grateful to have the Professor Azad Khan, Professor Fazlur Rahman Sir, BARDAS authority, the massive work parallel to the government they're doing day in and day out in Bangladesh, not only diabetic patients, the patient from neurosurgery, vascular, cardiothoracic, and now hopefully there is a drive to create a BARDAS cancer hospital within the BIHS in near future, very soon, hopefully, to integrate and help the poor people of our country, not only the elite who can go anywhere in the world. So with all this, I think if I have missed anyone and anyone would like to comment, Professor Salma Afroz, Madam, with your ample of experience in Bangladesh, working in various leading institute, if you would like to say a few words.
I want to add some words. Mahfouz has said about their treatment procedure, but they have patient 80% in government sector or 5% there. In government sector, the main burden is patient. The second thing is constraint of money. Third thing, the patient are coming, but they don't get bed even in the floor. We have to give them treatment. And there is the one important point is, in our country, we don't want to respect other department colleagues. We think I know everything, but it is very much needed. I have a small bad experience. In an institute, I don't want to mention the name, a patient was diagnosed psychosis. Again and again, he was given treatment for the last 3 or 4 months. He's coming, getting high dose steroids and all this and going back. I told them, I suspect this is a case of lymphoma, but they know the medicine opposes me. Many people opposes me. The radiologist also, he is a distant relation of a histopathologist. Then I pressurize them, and morphological examination along with immunohistochemistry, and it was diagnosed as a case of lymphoma. This is a very real picture in our country. But motivation of the patient is also important. We have very five-star clinics. Some of the patients, when they get this type of diagnosis, they go to big clinics. There they spend lots and lots of money for pinpoint diagnosis. And then they came back to government hospital and wants treatment in the floor. These are the points. Motivation is very important. Sometimes the patient are maltreated outside by ours, by other people. And COVID was telling that histopathology, that is tryptophan biopsy is needed, but in constrained facilities in our country. In case of acute leukemias, I worked many years, and I think if we can see very minutely, at least morphological diagnosis is there, then you cannot miss. If you correlate with the CBC, with the clinical situation. So we have to train our students. If we think very sophisticated investigation and all this is not possible in our country at a time, we have to, surely we have to, but we have to try to improve our learning and to give better treatment for the patient, because Mahfouz said their patient is coming, but our patient is not coming due to lack of money. Sometimes we call them, please come, but we don't have the money to come to your institute. These are the real stories. We know, but we cannot treat. Thank you. Thank you a lot.
Thank you, madam. What you're saying is affordability is a big challenge with a large population. And we do see in especially in Bangladesh, the child who has acute lymphoblastic leukemia in an ICHR has given one course of chemotherapy, you call 2003, and the next time they don't come. And they basically die. No one knows what happened. Why they didn't come? Knowing the parents knows that if they complete the treatment, 97% chance of cure, but they don't have any money. So they just keep one cycle chemo, they get better, and they just go and never come. In cancer hospital, there's thousands of patients comes in for radiotherapy. How many patient gets the radiotherapy? We need to create the facilities and better. And I'm pretty sure diverting some money towards the health would help as well. So thank you very much. The sarcoidosis is an example, and it is very common when you do a scan. We didn't have a CT scan in my medical college when I was a student, but now you have CT, and our respiratory physician, if they say, okay, this looks like sarcoid. Now many things looks like one disease, which we have learned 20 years ago, but actually it was a misdiagnosis. But now with the diagnostic utility, you can pinpoint and say, look, it is a sarcoid. We're treating sarcoid with steroid, is not working. We must take some biopsy after some off period of the steroid, and you get the diagnosis that way. So it must be a low-grade lymphoma your patient had, helped by steroid, otherwise this patient would have died. So this is what we see every day and every day.
Sorry, only 5 minutes left.
Yeah, sure. Any other panelist expert I have missed?
Beximco Pharmaceuticals were requested for 1 or 2 minutes to say something.
Yeah, so the vote of thanks by the Lipu Sarwar, I think, from the Beximco Pharmaceutical. Thank you very much, Beximco Pharmaceutical, for hosting this program for us. A timely meeting and wanting to do it together. So
thank you, sir.
Lipu Sarwar from Beximco Pharmaceutical.
আমাদের মার্কেটিং টিম থেকে কণিকা কাশপিয়া ও দিচ্ছে ভোট অফ থ্যাঙ্কস।
Assalamu alaikum. I'm Kashfi Rahman Konika. I'm the team leader of Beximco Oncology. Thank you for giving us the platform to be collaborated in this program and arrange this hybrid program with PHA and BIHS. Thank you so much. Basically, I'll just take 1 minute to highlight few points that you already know. Everyone acknowledge the quality that Beximco Pharma is striving to bring to the patients of Bangladesh. We are also in oncology segment right now. Very recently, we have started our journey in oncology segment. And in the same way, the way we have brought good medicines for the people of Bangladesh within affordability, we are trying our best to provide the same service to the patients of Bangladesh who are suffering from cancer. And we want to provide quality medicines to these patients as well within affordability. And to point out few drugs, we have brought a few biosimilar products, directly biosimilar products for the patients of Bangladesh within affordable prices. Currently, these medicines are available in Bangladesh at the lowest price that can be possible to be given to patients around the world. This is the lowest price in Bangladesh. We have brought Ogivri, which is a trastuzumab brand. And for the hematology segment, we have Fulphila, that is pegfilgrastim, within the most affordable price that can be available around the world right now. Alongside these biosimilar products that we have brought for the Bangladeshi cancer patients, we have other few products in our basket for the cancer patients, and for specifically for the ALL patients and CML patients, we have brought Tinicet, that is our imatinib. We have taken a while to bring this trusted medicine in Bangladesh. Basically, we have come very late, but there is a reason for coming late. We have talked about what a difference we can make in bringing this brand. So while we have launched, we try to think about the side effects that a drug may cause to the patients. So we worked on the side effect profile, and we tried to reduce the side effect profile so that the patients already burdened with cancer side effects, they do not get any more side effect from a drug again. So in this case, our imatinib is being made with the same formulation, the originator brand is being made. At the same time, we have tried to keep our impurity as minimal as possible so that our drug does not impose any additional side effect to your patients, because you already would acknowledge that the patients who are suffering from cancer, already they are burdened with huge side effect profiles from their disease already. So adding another side effect due to a drug which would cure them is not actually acceptable. Hence, we would like to offer our Tinicet for your cancer patients, or pediatric cancer patients and CML patients who can get the imatinib, your trusted molecule for a long time now. That's all from my end. I'll just request all of your support for our Bexenco Oncology portfolio. It's a very new portfolio. Your support would help us to go a long way. And I believe if you choose our drugs, our imatinib or Tinicet, your patient will get value for money. They will be more benefited due to the beneficial criteria of our drug, and they will hopefully be cured sooner and with a better profile. Thank you so much for giving me the platform. Thank you.
Thank you very much. I must say 1 minute about this drug, imatinib, which you mentioned. This is the forerunner, the first targeted treatment in cancer medicine. And we have now 170 TKI being used in most of the cancer, which improve, some of them being cured and improve the survival. And the hematologist, we are so fortunate that in cancer targeted therapy discovery, we are the forerunner because this drug is the first targeted molecules. Now we have many others, including CAR T-cell and bispecific and other cancer specialty, and the patient will benefit from it in years to come. So with all this, I think I would ask Professor Fazlur Rahman sir from BIHS General Hospital to make his concluding the final comment and conclusion of the session, please.
Thank you, Professor Amin Islam. Actually, today's interactive session was so fruitful, and the central theme, that is the integration between the therapeutics and the diagnostics. I think it's an enormous important issue. But before that, I again thank Professor Amin Islam for being with us from such a distant place. And as Professor Salahuddin from BSMM was saying that though you are in UK, but we strongly feel that you are every time with us, and we get you whenever it is needed. So thank you once again for arranging all this roundtable discussion. And today we got the opportunity to listen to so many experts from our country, from many institutions, and also from UK and Australia. Actually, BIHS is a hospital which is trying to come out of all the obstacles because it's not a, so to say, not a reach hospital. It's a hospital which is full of many constants, but we are trying to overcome all these. But this issue of today, that is the lack of communication between the treating physicians and the people in the labs. This is a real problem in Bangladesh. There are many aspects of this problem. You cannot say that there's a 1 or 2 or 3 problems. Actually, communication, lack of communication, our nation nourishes the problem. Everywhere there is a lack of communication. And culture, the culture of communication, it's really an important issue. Our culture is that we want to be segregated, and many of us are suffering from so many egos, which one of our speaker was telling like that. But things are coming out, days are changing, time are changing, and the psychology of people are changing, and especially our young generation, they are very promising generation, I must say. And I definitely hope that our young generation, they will bring out the change. That is, they will communicate each other, and they will bring everybody together. And the institutional cooperation between the all the disciplines, definitely they will help the patient's outcome. Actually, in your country, in UK or any other developed country, the working time is a long process. And one thing that in Bangladesh, this private practice and earning private money from the patients, it's a huge hindrance to develop, in fact, ourselves, this communication or the association between the disciplines and discussion amongst ourselves, because we are busy with this, and our government in different times took certain isolated steps to come out of it. But our doctors community is a very powerful community in this country, and the efforts of the governments who are not coordinated also. So I think if we could make, we dream that if the doctors would be whole-time worker, that is from 8 to 6 or something like that, then possibly many of our psychological aspects could be changed. But this is a national problem. We cannot help it out. So, but in our institute, we are gradually and slowly we are trying to bring the people together. Our one of our speaker, Mr. Mehdi Hassan, from he was telling that there is a role of a management also, because if the management does not the management does not feel that there should be improvement, there will be no improvement. So the management should try to develop things. And capacity building in different, especially in the different labs, it's a very important thing. We are a low resource organization, but still we are trying to develop capacities in our different labs, like immunology, like our microbiology, hematology, and histopathology, etc. And we are trying to develop immunohistochemistry very soon. We are at the trial stage of some antibodies, and next within 1 month we are planning to introduce the breast panel, and then possibly we'll be trying for hematology panel that is the lymphoma panel within this year. We hope to do so. So if we can do so, then our diagnostic deficiencies will be, this come out of to some extent. And we are encouraging our doctors to sit together, to talk together, and with an empathetic mind to our patients, so that we can bring a good outcome for our patients. And I can tell you that in our ICU and SDU, our outcome is very good. Now the dengue epidemic is running out in our country, but our hospital performance is very good. We had only 2 casualties during this regime, one in the child population and another in adult. And this is because of the cooperation, coordination between our clinicians. And I thank all of our consultants, professors, especially these pediatricians. They are coming to the hospital every evening, and they are, taking care of the patients. So there are so many, hemorrhagic shock syndrome patients, but none of them has died, and it's a great success of our hospital. So this discussion today was of tremendous value, and it bears a great implication for the nation, for the physicians, and naturally for the patients. So I again thank Professor Amin Islam and all the persons, all the consultants, all the people who made their time to join this roundtable discussion meeting, and contributed for the cause of the patients and for the cause of improvement of the health service as a whole. So I again thank you everybody from the platform of PISS. Thank you so much.
Thank you very much, sir, with your ample of experience leading and being the principal of various government and private medical college hospital. I'm sure that this directional talk will inspire us all. Professor Azad Khan, I see is still connected. Professional Professor Azad Khan, sir, if you are still connected, say a few words. If you are still connected, I can see he is still logged on. I think he's busy with the other call. So with all this, thank you all very much coming together. This is such a short notice, and we had this very timely discussion, and hopefully from this we can have some direction and create some integrated medical, surgical, and oncological pathway to help our patient in months and years and decades to come. Thank you all. Thank you, PHN. Thank you, the Beximco Pharmaceutical. Thank you very much. And the biosimilar is very important. One thing they say, it reduces the price so significantly globally and increases the affordability of patients to cure our patient as well. So thank you all together. Thank you.
Very nice.
Thank you all.
Thank you.
Thank you all.